The pregnant woman who trusted her doctor. She was 32 years old, 36 weeks pregnant, a mother of a 4-year-old son. She worked as a school teacher. She had no medical training. She had never heard of unstable angina. She just knew something was wrong. One night she felt it, a heaviness in her chest, not crushing, just a dull, persistent pressure. She thought, maybe it is heartburn. She was 36 weeks pregnant after all. Heartburn was normal, but the pressure came back the next day, and the next. And then, one morning, she could not catch her breath. Walking up the stairs, she went to her doctor. He listened. He examined her. He ordered an electrocardiogram, an ECG. The result came back, normal. The doctor said, "Your heart is fine. It is just heartburn. It is very common in pregnancy. Go home, rest, take antacids. You will feel better." She wanted to believe him. She was not a doctor. She did not know why a normal ECG could be wrong. She did not know why chest pain in pregnancy could be a heart attack. She trusted him, so she thanked the doctor. She walked out. She went home. 3 days later, she collapsed in her kitchen. Her husband found her on the floor. The baby was still alive inside her, but her heart was failing. Now here is the question that haunts me. Why did a normal ECG miss a dying heart? Why did a doctor send a pregnant woman home with chest pain? Why did an ordinary woman who trusted her doctor become the mother who nearly died? Let me answer those questions, because the answers will save lives. I am Dr. Ravi Chani. You are listening to Red Flag MD. This is not a lecture. This is a checklist course. Case number 4 from the outpatient department Red Flag Files. You have few minutes. Let us see how many practice-changing insights you can collect. And remember, every insight here is a red flag you can use to protect your patients and yourself. So let us begin. The first red flag, the pregnant patient with chest pain. Here is the first red flag. She was pregnant and she had chest pain. Why is pregnancy a red flag? Because pregnancy changes everything. Why does pregnancy change everything? Because the blood volume increases by nearly 50%. Why does blood volume increase? Because the body is growing a placenta and a baby, and both need blood. The heart rate increases by 10 to 20 beats per minute. Why does heart rate increase? Because the heart has to pump that extra blood. The cardiac output increases by 30 to 50%. Why does cardiac output increase? Because the heart is working harder than it ever has. Here is a trivia for you. A pregnant woman's heart at 36 weeks is working as hard as an athlete's heart during moderate exercise, all the time, even at rest. So why do doctors dismiss chest pain in pregnancy as heartburn? Because heartburn is common. Up to 80% of pregnant women have heartburn. But here is the danger. Why is heartburn different from cardiac chest pain? Because heartburn is a burning sensation behind the breastbone. Cardiac chest pain is pressure, or heaviness, or tightness, or pain with exertion. Why does the distinction matter? Because heartburn is uncomfortable. A heart attack is deadly. The 2020 European Society of Cardiology guidelines state that pregnant women with chest pain require the same evaluation as non-pregnant patients. Why? Because pregnancy does not protect against heart disease. In fact, it increases the risk. Here is your red flag. Do not dismiss chest pain in a pregnant woman as heartburn. Not until you have ruled out the dangerous causes. Why? Because the dangerous causes kill mothers, and mothers are not supposed to die. The second red flag, the normal ECG, that meant nothing. Here is the second red flag. The doctor ordered an ECG. It came back normal. Why did the doctor trust a normal ECG? Because he was taught that an ECG is a good test for heart attacks. But is it? Here is a trivia that will change how you practice. A 2019 study in the Journal of the American College of Cardiology found that up to 40% of patients with acute coronary syndrome had completely normal ECGs at presentation. 40%, almost half. Why does the ECG miss so many heart attacks? Because the ECG measures electrical activity at a single moment in time. Why is that a problem? Because if the ischemia is intermittent, coming and going, the ECG may be normal between episodes. Think of it like this. If you take a picture of the ocean, you cannot tell if the tide is coming in or going out. You need a video. The ECG is a picture. The heart attack is a movie. Here is another trivia. The sensitivity of a single ECG for acute coronary syndrome is only about 50%. Why is it so low? Because the heart has to be having the heart attack at the exact moment the ECG is taken. If the pain comes and goes, you might catch it, or you might not. In pregnant women, the numbers are even worse. Why? Because the heart rotates during pregnancy. Why does the heart rotate? Because the diaphragm pushes up, the uterus expands, and the heart shifts position. The ECG electrodes are placed in the same spots, but the heart has moved. A 2021 review in the journal Circulation stated that ECGs in pregnant women are more likely to be falsely normal because of these physiological changes. Why does this matter? Because doctors use the same reference ranges for pregnant and non-pregnant women, and they miss the diagnosis. So here is your red flag. Why should you not trust a normal ECG in a pregnant woman with chest pain? Because the test was not designed for her body, and the test is not as good as you think. The reveal at the moment of collapse. Now, let me tell you the rest of the story, because this is where the audience will feel the weight. She was rushed to the emergency department. Her blood pressure was crashing. Her oxygen was dropping. The baby's heart rate was decelerating. Why was she crashing? Because her heart was not getting enough blood. The artery that feeds the front wall of the heart was almost completely blocked. The emergency team worked frantically. They intubated her. They performed an emergency C-section in the resuscitation bay. Why? Because the baby was dying too. The baby came out crying. A healthy girl. 6 pounds, 7 ounces, but the mother was still dying. The cardiologist looked at her ECG. Still normal. He looked at her troponin. It was elevated, but not dramatically. He said, "This does not look like a classic heart attack." Then he asked the husband a question. "Did she have any chest pain before this?" The husband said, "Yes, for 3 days." She went to the doctor. The doctor said it was heartburn. The cardiologist stopped. He said, "Why did no one listen to her? A pregnant woman with exertional chest pain and a normal ECG is not heartburn. It is a heart attack until proven otherwise." Here is a trivia that every cardiologist knows. The widowmaker, the left anterior descending artery, supplies 50% of the blood to the heart muscle. Why is it called the widowmaker? Because when it blocks, the heart fails. And the ECG can be normal until the blockage is nearly complete. They ordered a coronary angiogram, and there it was, a critical stenosis in her left anterior descending artery. 90% blocked. Why was the ECG normal? Because the blockage was not complete. Blood was still getting through at rest. But when she walked, when she climbed the stairs, when her heart needed more blood, the artery could not deliver. She had unstable angina. The ECG was normal because the ischemia was intermittent. The troponin was only mildly elevated because she had not yet had a full heart attack, but the artery was 90% blocked. She survived, but she has a pacemaker now. Why? Because the heart attack damaged the electrical system of her heart. She cannot have another baby. Why? Because pregnancy would put too much strain on her damaged heart. She cannot go back to teaching. Why? Because she cannot stand for long periods. She cannot run after her 4-year-old son. She watches other mothers push strollers. She watches other teachers in their classrooms, and she knows her life will never be the same. Here is a red flag that Red Flag MD wants you to carry with you. Why should you never wait for a patient to crash before you listen? Because by then it is too late. The damage is done. The life is changed forever. Insight 1. Why the ECG was normal. Let me explain why the ECG was normal. Because this is where most doctors get it wrong. The electrocardiogram, or ECG, measures electrical activity at a single moment in time. Why does that matter? Because if the ischemia is intermittent, coming and going, the ECG may be normal between episodes. Think of it this way: if you check your blood pressure once a day, you might miss the spikes. If you check your temperature once a day, you might miss the fever. The ECG is the same. The 2020 European Society of Cardiology guidelines state that a normal ECG does not rule out unstable angina. Why? Because unstable angina, by definition, is a clinical diagnosis based on symptoms, risk factors, and pattern, not on ECG. Here is a trivia that will change how you practice. A 2018 study in the New England Journal of Medicine found that patients with unstable angina and normal ECGs have the same risk of death or heart attack as patients with abnormal ECGs. Why? Because the ECG does not predict the risk. The symptoms do. Here is another trivia. The sensitivity of a single ECG for acute coronary syndrome is only about 50%. Why is it so low? Because the heart has to be having the heart attack at the exact moment the ECG is taken. So here is your red flag. Why should you not trust a normal ECG in a patient with exertional chest pain? Because the test is not sensitive enough. Why should you not trust a normal ECG in a patient with chest pain relieved by rest? Because the pain is coming and going, and so is the ECG finding. Why should you not trust a normal ECG in a patient with risk factors? Because the risk factors are still there, even when the ECG is normal. Trust the story, not the test. The third red flag, the word probably. Here is the third red flag. The doctor said, probably just heartburn. Why is the word probably dangerous? Because probably is not evidence. Probably is a guess, and a guess is not the standard of care. Why do doctors say probably? Because they are busy. Because they want to reassure the patient. Because they have seen 100 cases of heartburn and only one heart attack. But here is the problem. The one heart attack is the one that kills. Here is a trivia that will surprise you. Heartburn in pregnancy affects up to 80% of women, but chest pain is not heartburn. Why? Because heartburn is a burning sensation behind the breastbone. It is not pressure. It is not heaviness. It is not pain with exertion. The doctor in this case did not ask the right questions. Why did he not ask? Because he was anchored to the normal ECG. He saw the normal result and stopped thinking. Here is your red flag. Why should you never say probably to a pregnant patient with chest pain? Because probably is not a diagnosis. Probably is a risk, and risk needs to be managed. Insight 2. The 3 scenarios where a normal ECG hides danger. Let me give you 3 situations where a normal ECG hides dangerous cardiac disease. Each one is a red flag, and each one could save a life. First, unstable angina. The patient has chest pain. With exertion, the pain is relieved by rest. The ECG between episodes is normal, but the artery is critically stenosed. Why does this happen? Because the blockage is not complete. Blood flows at rest, but not with exercise. The ECG is normal at rest, but would be abnormal during exercise. Here is a trivia. The average time from symptom onset to diagnosis of unstable angina is 2 to 3 days. Why so long? Because patients come in, get a normal ECG, and are sent home. Again and again. Here is your red flag. Why should you not trust a normal ECG in a patient with exertional chest pain? Because the pain comes and goes, and so does the ECG finding. Admit the patient, check serial troponins, or arrange urgent cardiology follow-up. Second, myocarditis. The patient had a viral illness 2 weeks ago. Now they have chest pain, fatigue, palpitations. The ECG is normal. The troponin is normal, early. Why does this happen? Because the inflammation is early. The heart cells are inflamed but not yet dead. Troponin rises when cells die. ECG changes when electrical pathways are disrupted. In early myocarditis, neither has happened yet. Here is a trivia. A 2021 study in the journal Circulation found that over 40% of patients with confirmed myocarditis had normal initial troponin levels. Almost half. Here is your red flag. Why should you not wait for tests to turn positive? Because by then, the inflammation has already damaged the heart. The 2021 European Society of Cardiology guidelines state that any cardiac symptom within 1 to 3 weeks of a viral illness should be evaluated for myocarditis. Not observed, evaluated. Third, pregnancy-associated coronary artery dissection. This is a rare but deadly condition. The inner layer of the coronary artery tears. Blood gets trapped between the layers. The artery closes. The patient has a heart attack. Why does this happen in pregnancy? Because of hormonal changes that weaken the blood vessel walls. Because of increased blood flow that stresses the arteries. Because of the physical strain of labor and delivery. Here is a trivia that every obstetrician should know. A 2020 study in the journal Circulation found that pregnancy-associated coronary artery dissection is the leading cause of heart attack in pregnant and postpartum women. Why? Because it is often missed, and the ECG is often normal or minimally abnormal in the early stages. Here is your red flag. Why should you not stop at a normal ECG in a pregnant patient with chest pain? Because the most dangerous cause is the one that hides. Consider coronary artery dissection, order an echocardiogram, or refer for urgent cardiology evaluation. Insight 3. The legal lens. Here is how the lawyer will destroy this case in court. The patient was 32 years old, 36 weeks pregnant, a school teacher. She presented with exertional chest pain. Why did you not admit her? Why did you not check serial troponins? Why did you not warn her to return? Why did you trust a normal ECG when the guidelines say a normal ECG does not rule out acute coronary syndrome? The lawyer will say, the doctor did not follow the guidelines. Why do guidelines exist? To protect patients from doctors who stop thinking. The court does not care that the ECG was normal. Why? Because the court knows what every cardiologist knows. A normal ECG does not mean a normal heart. The court cares that you did not listen to her story. The court cares that you dismissed her because she was pregnant. The court cares that you stopped thinking when you saw the number. Here is your red flag. Why should you document your reasoning? Because documentation is the only thing that shows the court you were thinking. Insight 4. The documentation that saves you. Here is what you write. Not just ECG normal, but this. Patient presents with exertional chest pain for 3 days, relieved by rest. 36 weeks pregnant. ECG normal. Why am I not reassured? Because a normal ECG does not rule out acute coronary syndrome in a patient with typical symptoms per European Society of Cardiology guidelines. Why am I admitting her? Because she needs serial troponins and cardiology consultation. Why am I safety netting? Because if she goes home and her symptoms worsen, she needs to know to come back immediately. That paragraph does 3 things. It shows you recognize the red flag. It demonstrates you followed the guidelines. It creates a legal record that protects you, and it shows the court why you made every decision. The question that keeps you awake. Before we close, let me ask you something, and I want you to be honest with yourself. Why did the doctor miss this diagnosis? Because he trusted the test more than the patient. Why did the patient nearly die? Because she trusted the doctor more than herself. Have you ever done that? Have you ever trusted a normal test when the story was screaming at you? I have asked myself that question more times than I care to admit. Why? Because the answer is uncomfortable. If you have a story, a lesson, a moment that changed how you practice, I want to hear it. Drop it in the comments if you are watching on YouTube, or send me a message if you are listening to the podcast. The guidelines exist, the evidence exists, the tools exist. The only question is, why do we not use them? This is Dr. Ravi Chani. You have been tuned to Red Flag MD. I will see you in the next checklist course. Take care.